Welcome back to Therapeutics. In this third set or themes in mental health, we'll talk a bit about the agents used for mania and bipolar states. We'll differentiate among the treatments used for mania, including antipsychotics and antiepileptic drugs and lithium, and we'll indicate sort of where these agents will fit. When we talk about mood disorders, let's differentiate in bipolar situations. The agents that we're going to use in bipolar include as baseline agents either lithium or valproic acid, carbamazepine, or maybe lamotrigine. And as we review bipolar, consider the criteria for bipolar. There are subtypes of bipolar, type 1 and type 2. This table differentiates mania from hypomania in both its severity and its identification. This graph indicates for type 1 versus type 2, which are first-line versus second-line agents. And what you'll see here in the first-line agents, lamotrigine has become more commonly used for maintenance with both type 1 and type 2. Sometimes lithium or valproate plus an SSRI or bupropion makes sense, again, for type 1, where we use quetiapine more commonly for acute management in someone with type 2.
Guidelines in the United States haven't changed that much in the last 4 or 5 years or so, but I thought I'd include some guidelines international for the acute mania that is. Uh, I will tell you that I don't have direct experience with this. I usually see patients who come into the acute care hospital just on maintenance therapy and not managing acute mania. But here's what some of the issues from Australia and New Zealand have sort of recommended. They first look in the management of acute mania to look at whether or not the patient has symptoms of agitation or psychosis, and then pick an appropriate antipsychotic. And some of the agents that are used there are a little different than maybe the ones that are used here. But also in conjunction with a mood stabilizing agent and maybe one of those second generation antipsychotics that are sort of listed here to control agitation and or psychosis. On top of that, the mood generation agents they look at are either valproate or lithium. I know in the United States, lamotrigine seems to be a more commonly used agent that I've seen patients come in on. When you're looking at bipolar depression with depression as a component, their recommendations for monotherapy are mood stabilizing agents more so than the second generation antipsychotics. And their recommendations there are lithium or lamotrigine or valproate. And I think what I see, at least most of our colleagues here in the United States, sort of waiting for lithium in situations that are refractory to either lamotrigine or valproate because of its narrow therapeutic index. In mixed states, they also have some recommendations that are listed in this chart, which is a little difficult to read. And because I don't do this all the time, I have to tell you honestly, there are subtleties buried in this that I'm going to defer to your clin med folks, or particularly when you do a mental health rotation or behavioral health rotation, or if this is a situation you're going to see commonly. I think, though, when you're looking at issues, you're trying to define to what degree is there mania versus to what degree is there depression, and then target for mania, if it's very acute, to target with a second generation antipsychotic to keep a mood stabilizing agent running through, and then for depression, whether or not one or more agents might be more helpful there. And according to at least these recommendations, I think that losartan is sort of becoming an issue used in a drug used internationally for mixed states with depression. Uh, and finally, here, their management of maintenance in bipolar, trying to go with monotherapy if that makes sense for the patient, usually with a mood stabilizing agent, and unless the mania is significant, for which you want to maybe look at aripiprazole, for example. And if it's depression, lamotrigine again seems to have a niche in depression and bipolar, folks with bipolar?
We're going to start with lithium. Lithium is an agent that's been around for a long time, and if you think about lithium, lithium is an agent that is on the periodic table. And this is important. Why do we show this? Not to badger you about chemistry, which you may or may not have had a good experience with. More of what we do this for is for having you remember that lithium and sodium are quite similar and close. And in a sense, when the body is sodium deprived, it may try to hold on to as much sodium as it can, but in that process, it may also hold on to a lot of lithium, and patients predisposed to becoming lithium toxic. So lithium has been around for a number of years, and in fact, in the 1930s, lithium was in a beverage, a soda, that was quite popular at the time, and it's still. I think the drug is still. I mean, this soda is still available, but no, it does no longer contain lithium in it. And that magic soda that contained lithium was, drum roll please, 7-Up. So 7-Up actually used to contain lithium in it. Lithium is used for primarily for manic or depressive episodes of folks with bipolar. It's not particularly good as an antidepressant as singular therapy, and truth be told, there are safer agents to use than lithium for monopolar depression or unipolar depression. But if folks have a manic component associated with depression and bipolar, lithium's actually quite effective, and you begin to see full effects pretty early with lithium compared to many other drugs we use in mental health. You begin to see some effects within a week or two. Lithium has a half-life of somewhere in the range of 20 to 24 hours. Most of it's excreted unchanged by glomerular filtration, which means that lithium dose has to be adjusted for renal dysfunction. So we pay a close attention to lithium levels, particularly in someone who has some modest renal impairment or any renal impairment at all, and we're careful about how we use lithium for that in that patient. The initial dosing for lithium varies, but typically we see 300 milligrams twice a day, 450 milligrams twice a day, 900 milligrams a total daily dose is usually where the max where we start. So either 300 BID or 450 BID is typically where we start. There are a couple of long-acting lithium forms. You can titrate somebody to one of those longer-acting lithium forms and make it a little easier with dosing, but usually we start with standard lithium carbonate. And before we start lithium, we need to get a full workup for folks. So you want to get their CBC, look at their electrolytes, renal function, thyroid function tests because lithium can affect thyroid function. Get a urinalysis, find out what their renal function is. You want to get an EKG. You want to look for pregnancy testing in any woman of childbearing age. And then while they're on lithium, we want to monitor their lithium levels. Most of the time, our goal range is 0.8 to 1.2, particularly for acute mania. And then once somebody's in maintenance, they can often be maintained at 0.6 to 1 milliequivalent per liter. We typically are going to get a level first thing in the morning before their morning dose, really usually 12 hours after their last dose or the lowest point of the day. Peak levels of lithium, levels, an hour or two after a dose don't really mean a lot to us. So we really want to get a trough level before the morning dose usually. And we want to get periodic renal function tests, partly because for two reasons. One, lithium is excreted renally, so if their renal function falls off, then you need to adjust downward the lithium dose. The other concern is that lithium itself may be nephrotoxic. Now, there's been a lot of debate over this for the last few decades, but most clinicians believe that over time, long-term patients on lithium may have some deterioration in renal function. And if that's true, we keep an eye on that and we reevaluate if their renal function falls off a bit. So important to do that. So we'll get renal function tests, also thyroid function tests and urinalysis every 6 to 12 months. Most of that is the thyroid function is any alteration there is usually reversible when you stop the lithium. The renal function deterioration may or may not be secondary to reversible when you stop the lithium. We also need to keep a close eye for lithium toxicity. Lithium toxicity presents on a level or dose-related kind of toxicity. Early on, you'll see someone lethargic, maybe having a coarse tremor. Or as levels get higher, they have a change in mental status with confusion, even higher level seizure, and ultimately could be coma and even death at very toxic levels. And that can happen pretty quickly. So someone who can get initially lithium toxic, they start to accumulate lithium pretty quickly. One of the toxicity you can see early on with lithium is diarrhea. So if folks have diarrhea, we need to think about, gee, is this lithium toxic? And you stop for a moment and think about why diarrhea as an early manifestation of lithium toxicity is so dangerous. Did you think about why diarrhea might be so dangerous in a patient with lithium toxicity? What do you lose when you have diarrhea? You lose sodium. So early on with lithium toxicity, you have someone who has some diarrhea. They lose sodium. What's the kidney going to do? The kidney's going to hold on to as much lithium as it can, and lo and behold, they become more lithium toxic because the diarrhea they have in early lithium toxicity accentuates the body holding on to more lithium, reducing its excretion, and lo and behold, you have full-blown lithium toxicity with confusion, seizures, maybe even coma. So important to get a handle on lithium toxicity early. So as we alluded to, a narrow therapeutic index drug, we need to get blood levels. Lithium is one of the few drugs, particularly in mental health, that we do that for. We'll get a level the first in the morning, 12 hours after the evening dose. We look for the therapeutic range and look at potential risks for toxicity. What you'll see for adverse effects with lithium, as we alluded to, we can have renal toxicity. Early on, that could be manifest as polyuria and polydipsia. That's pretty common. So folks will pee a lot and be very thirsty. Then they will see over time, perhaps a decrease in their creatinine clearance. Long term, their causality of that is not really clear, but it can happen. Other short-term adverse effects with lithium, central nervous system could be tremors with sedation, slurred speech, vertigo. The higher the serum level is, the more complicated and more impaired that patient will be. GI toxicity can manifest fairly early with nausea, vomiting, diarrhea, anorexia. It's dose-related. Endocrine-wise, you can see hypothyroidism, which is why we get baseline thyroid function tests for folks on lithium. Another reason we get baseline thyroid function tests is that if someone is in mania or hypomania, it could also, the symptoms of hyperthyroidism can actually mimic mania. So you want to rule out hyperthyroidism at the same time. And hematologic, you can see a leukocytosis. Clinically, doesn't mean the person's infected, but they will see an elevated white count modestly while folks are on lithium, and it's really nothing to get overly concerned about, but we watch that. Doesn't usually mean infection. It just kind of is associated with lithium therapy. So let's look at dose-related toxicities. Anybody who has any renal insufficiency or early lithium toxicity can develop worsening toxicity. Early on, folks may have ataxia, lack of coordination. When the levels are moderately high, nausea, diarrhea, coarse tremors, maybe slurred speech. As it gets higher, the tremors are more coarse, more pronounced. The patient may have confusion, profound delirium, or ataxia, and ultimately can have a loss in consciousness, leading seizures, coma, even death. So all of these are important to recognize for a patient on lithium, and to, as you relay to a patient the concerns for lithium, you want to talk about these side effects, talk about how important it is early on to get seen. Don't wait. If you start to have diarrhea or vomiting or you tremor or you don't feel yourself, you need to call the office right away. If it's on a weekend or in the evening, you need to call the on-call person who can encourage you what to do. You stop taking your lithium probably, but you wait for the provider's advice on that. So you want to give them a good little bit of healthy fear in that discussion so they know how serious it is, but you don't want to paint the picture so dire that they won't adhere to lithium at all. So you've got to find, you've got to work the balance with that patient about how do you relay to them the importance of monitoring for toxicity without getting them pretty freaked out about the whole thing so they don't adhere to therapy. So here's another table that includes some of the adverse reactions and the kind of things you may do for these things. Let's go through these. With the rash, we obviously are concerned about a hypersensitivity reaction, so would stop lithium. Tremors, we usually look at the blood level and adjust the dose accordingly. For folks who are in the therapeutic range but still have important tremors, there's some data for beta blockers. We're usually keen in not creating too much polypharmacy, so we don't like to do that unless we really have to. Any symptom of toxicity, though, CNS toxicity, GI, we all look at levels to make sure that's going to guide our decision about whether or not those symptoms are dose-related. Hypothyroidism, typically we can either look at a different agent than lithium or look at starting them on levothyroxine, being careful about that. Polydipsia or polyuria, sometimes reducing the dose can work. There is data that a thiazide diuretic may help with polydipsia, polyuria. It's kind of convoluted in thinking. It's kind of a paradoxical kind of reaction, but that really can work sometimes. But if you do that, you have to be aware that the sodium loss is going to result in elevated lithium levels, and so you need to reduce the dose and then keep levels going and retitrate their dose to a lower dose if you're doing that. We don't usually recommend that. We also worry about renal function, so interstitial fibrosis, glomerulosclerosis is basically the way we do that is we avoid dehydration in a patient, and we look at the lowest effective dose that they can be maintained on. It's also teratogenic, so we look at avoiding it during the first trimester of pregnancy, particularly. There are going to be rare circumstances where you weigh the risk and the benefit. So if, for example, a woman of childbearing age and their mania is very severe, they've not responded to anything else, and the mania is a potential danger for coming to full term with a healthy infant, and manic behavior can be quite dramatic and risky for the mother and the fetus. Maybe it does make sense that the benefit of lithium and controlling mania outweighs the risk to the fetus, but that's a decision that gets made and probably above the level of a PA. You're going to work with psychiatry, your primary care, obstetrics, to kind of make that kind of evaluation or decision about lithium use in a woman who could be pregnant. There are a number of considerations to think about lithium because it's problematic. Anything that affects sodium, diuretics, NSAIDs, ACE inhibitors, and the like are all sort of, you want to look at managing these interactions with them. Pregnancy, you want to be careful about as well. In older folks, you typically need less lithium as well. So all of these are sort of things to think about in folks who are on lithium. So again, we alluded to the lithium and the sodium issue.
Let's just spend a moment talking about drug interactions with lithium. There are a number of them with lithium, and being a narrow therapeutic index drug, as clinicians, we're really concerned about anything that could result in different lithium levels or a different lithium response. So anything that affects sodium is going to be problematic with lithium. Certainly changes in sodium intake, but also at the bottom of the slide, diuretics. And diuretics, they're not absolutely contraindicated, and there's actually some data for using a low-dose thiazide diuretic with folks who have diabetes insipidus with lithium, but we do that very, very carefully because the concern is that we're going to increase sodium elimination and therefore affect lithium reabsorption. So if we were to consider that in any person, would want to probably look at carefully monitoring lithium levels and maybe even doing a little dose reduction in lithium in advance to monitor for that. Nonsteroidals also can be problematic both for increased lithium levels, but also for posing an added stress on the kidney and maybe increasing the risk for kidney dysfunction secondary to lithium and the nonsteroidal together. And so more on that and renal dysfunction later in the curriculum, but really important for us to think about avoiding NSAIDs or ACE inhibitors, or at least being careful with their use and have a compelling reason to do that. Other interactions with lithium include at least some risk with the antidepressants or the triptans for migraine headache or linazolid as an increased risk for serotonin syndrome as it relates to elevated neurotransmitter levels and serotonin levels that lithium can, in a sense, augment. So being careful about that. And then lots of risks for interactions with lots of other drugs, but there's a smattering of them that might have some added neurotoxicity associated with them. The anti-epileptic drugs certainly make sense, phenytoin, carbamazepine, where we could expect that, and a little more on neurotoxicity in the neurology block. But you can see it with other drugs too, like the calcium channel blockers, diltiazem and verapamil. And this is sort of a hodgepodge of interactions with lithium, but lithium as a narrow therapeutic index drug is associated with a fair number of interactions that clinicians want to be careful about.
Let's switch gears now to the role of anti-epileptics or anticonvulsants in the treatment of mental illness, particularly relates to bipolar. This content's pretty much covered in neuroblock, but it's also an important issue for us in mental health as well. So one of the things we think about with any of the agents for treating epilepsy is we're looking at usually affecting one of the ions that affect neuronal firing. And sort of in the same way, in a sense of how we thought about the action potential in cardiovascular electrophysiology, in a similar way we think of that same general idea here in neurology. So neuronal firing, the key things we think about are sodium or potassium or chloride, and where those ions are in or outside the neuron, and channels that allow sodium or potassium or affect chloride, and how these agents will interfere or slow down electrical conduction by inhibiting perhaps the ion transfer across that channel. So we have a number of anti-epileptic meds that affect sodium channels. 3 of them are used in mental health. Those are carbamazepine, lamotrigine, and valproic acid. We also will talk later in the year about phenytoin or dilantin, zonisamide, lacosamide, oxcarbazepine. But typically in mental health, the 2 big ones are lamotrigine and valproic acid, to some degree carbamazepine as well, although I'll tell you truthfully, I don't see nearly as much carbamazepine in the last decade in mental health as we did probably in the 1990s and 2000s. A second set of drugs that affect neuronal conduction is actually affecting GABA transmission or GABAergic. If you may remember, early in the summer, we spoke about GABA receptors, and what GABA does is it slows neuronal firing. So if we have a drug that enhances or is an agonist at GABA receptors, that actually slows neuronal conduction. And the anticonvulsant drugs that do that are felbamate, gabapentin, the barbiturates, and the benzodiazepines. And of these, it's really the benzodiazepines that are also used in mental health, particularly for anxiety conditions. We use benzos for other purposes as well. We also have drugs that work through the T calcium channel, and this appears to be correlated with, in seizure control, with a management of a certain subtype of seizures called absence seizures or petit mal seizures. We'll talk more about that in neurology, but the 3 drugs that work in this channel are valproate, which we also use in mental health, ethosuximide, and zonisamide. So let's talk about some of the key drugs we talk about in this block. One is carbamazepine or Tegretol. And even though we don't use it as much in mental health as we used to, we still see it used. Tegretol or carbamazepine works to slow the rate of voltage-regulated sodium channel activity, indicated primarily for generalized tonic-clonic seizures or partial seizures. We'll talk more about what those are in neurology in the spring. But we also use them for bipolar affective disorder, and they're also used for neurogenic pain management, particularly trigeminal neuralgia. The oral Tegretol is well absorbed orally, about 75 to 85% of it is. It's metabolized to a pharmacologically active metabolite, and sometimes that active metabolite can accumulate in some patients and contribute to the sense that they almost look like they're drunk. So we see some CNS toxicity associated with that. Interestingly, and we'll come back and talk about this later in the year, in the spring, but Tegretol does something called autoinduction. That typically when you start somebody on Tegretol, their half-life might be reasonably long, but after a few weeks to a few months, what you end up with is creating more enzymes that metabolize Tegretol, and so the half-life goes down, the clearance goes up, the metabolism goes up. And so you'll start somebody on a dose of Tegretol and get a level, and the level is where you want it, and you say, gee, the level is great, they're fine, they come in a month later, and the level is subtherapeutic, and your first suspicion is, gee, this patient has not been adherent to their medication. More often, it's that this autoinduction has taken place, so we keep about that. So typically what you'll see is that folks will get to steady state in 4 or 5 days, half-life close to a little over 24 hours. But what you'll see in a month later is you want to get a level again because their level is likely lower after this autoinduction has kicked into gear. The therapeutic levels for Tegretol are 5 to 12 milligrams per liter. Levels on the higher side are associated with these CNS side effects, double vision, lethargy. You can also see a lot of GI distress, particularly when we start the drug. And so because this drug is only given orally and it's associated with a lot of GI distress, we can't give folks big loading doses. We have to start Tegretol at a low dose and titrate upward over a couple of weeks. And so what you'll find often is that we'll start somebody on 100 milligrams twice a day for a day or two, and then 200 milligrams twice a day for a day or two, and then and work our way up to whatever dose we're shooting for. The other issue that this drug does, a couple of things with this drug. One is that it's associated with bone marrow suppression and a drop in white count. When the drug first was available, people made a big fuss about this. In fact, people were as concerned about it when the drug came out as they still are about clozapine or clozaril. But truth be told, this suppression in white count with Tegretol is usually not severe. It's usually not problematic. If you had somebody who was already neutropenic, if they've had chemotherapy, they've had some other reason where they're already neutropenic, then yes, Tegretol would not be the drug for them. But most of the time, we just monitor for it, and as long as the patient's white count is okay and they're not infected and not otherwise immunosuppressed, usually it's fine. And we usually don't make a big fuss about it like we did when the drug first came out. We didn't know as much about what to expect from it. The other thing we see is sometimes you'll see fluid retention and the syndrome of inappropriate ADH secretion. And this can be sometimes quite dramatic. You can see folks with very low sodiums, sodium level of 125, which gets problematic. The way we typically manage this is to ask folks to have some fluid restriction to try to decrease the amount of free water intake. That usually does the trick. Sometimes, though, we need to actually stop Tegretol and consider another drug. So that is sometimes problematic for some patients. Valproic acid, fairly commonly used in mental health. It works on the recovery of voltage-activated sodium channels, which is probably why it works in mental health. Also, as we alluded to, it affects T calcium channels and increases the availability of GABA. We use it mostly for generalized tonic-clonic seizures, partial seizures, also absence seizures, but it's also used for mania and sometimes used also for migraine headache prophylaxis. pretty well absorbed orally. It's also available intravenously. Pretty highly protein bound. It's metabolized to a lot of metabolites, some of which are probably pharmacologically active. Has a half-life in adults of typically 12 hours or so. Typically, you can get the steady state in 2 to 4 days. Therapeutic levels typically for seizure control is 50 to 100 milligrams per liter, but in mental health we have a broader therapeutic range. Down to 40. Some folks, their mania is controlled at a level around 40 milligrams per liter. Other folks need levels as high as 125 milligrams per liter to be effective in mental health. So our range for goals in mental health are a little broader. The adverse effects associated with valproic acid, GI upset, the using of a longer-acting form, we'll talk about in a minute, seem to help. Weight gain, though, is very common with valproic acid. Typically, patients who start on VPA will gain 10 kilograms, sometimes as much as 20 kilograms of body weight over the next couple of months. That's not fluid weight. Typically, what we see with folks on valproic acid is they never seem to be satisfied with what they eat. They always want to eat more. They have this drive, this hunger, this sense of wanting to eat more, and that's pretty common with valproic acid. So if you've got somebody for whom a weight problem is an issue, valproic acid is probably not your first go-to drug unless there's other reasons why it makes sense to use it. The other concerns we see, when the drug first came out, we had a concern for hepatitis, for liver injury, so we do get liver function tests on it. It's probably not as big of a deal. The patients for whom liver function toxicity has been really problematic are in two subpopulations. One are young children under the age of 4 or 5 years of age, particularly under the age of 2. And the second population might be folks who have developmental disabilities where there's a greater risk for that. But truth be told, when that data was evaluated with liver function tests, when valproic acid was used pretty commonly in the 1980s in this subpopulation, many of those folks also, because of their institutional setting, were at risk or had hepatitis B, which affected their liver function tests as well. So I think the liver function issue, the drug got labeled with hepatotoxicity, probably, I'm surmising, more risky that it was a coincident factor in the population where the drug was being used. The other issues we do worry about, though, particularly that dose-related, particularly if the levels get above 100, is the risk for thrombocytopenia. And so we're going to watch thrombocytopenia, we're going to watch platelets, and if platelets get below 100,000, we start to think, hey, do you really need valproic acid? If we do, can we manage their levels a little bit lower? Can they tolerate a lower level so that we can keep an eye on their platelets? The usual dose for valproic acid is 15 milligram per kilogram per day divided every 6 to 8 hours. More often we use the Depakote, the divalproex form, which is a longer-acting form, and they even have a once-a-day extended release, extended duration form. There's a couple of different forms of this drug. So the original drug is valproic acid. Valproic acid has a little more GI upset when given orally, but it's also available intravenously, but you have to dose it usually every 6 hours. The Depakote, or the divalproex, basically they take two valproic acid molecules and link them together, and then they get cleaved slowly over the next few hours in the gut or in the bloodstream, and as they get cleaved, then you have a more longer duration of action and less GI upset. So the oral formulations that are most commonly used are divalproex or Depakote. And that Depakote comes in a number of different formulations. They come in a delayed release and an extended release. The delayed release still has to be dosed every 8 to 12 hours, while the extended release can be dosed once every 24. You just want to make sure as you're ordering it that you're ordering the correct product for the duration of your dosing interval. They also have formulations that are available as liquid valproic acid, sprinkles that you can sprinkle on food, capsules that can get opened up and sprinkled on food as well. And so all of that are alternatives we have, as well as an IV formulation as well. One of the last drugs we'll talk about in the anti-seizure meds is lamotrigine. Lamotrigine affects the voltage-activated sodium channels like we saw with the earlier agents. It's really second line for seizure control, but is pretty commonly used for bipolar. Its bioavailability is reasonable. It's metabolized to an active glucuronide metabolite. The half-life varies, though, dramatically depending on the drugs we have concurrently on board. And the real risk for this drug, particularly if it's dosed with valproic acid or an enzyme inhibiting agent, we see that its half-life is long and can accumulate, and lamotrigine in high levels can be associated with a higher risk for Stevens-Johnson syndrome, which is a very serious to life-threatening dermatological issue. What you'll see could be with Stevens-Johnson's is exfoliative dermatitis to necrosis around the mouth, which is very severe. And so anybody who gets a rash or any skin involvement problem on lamotrigine, we immediately stop the lamotrigine and evaluate what's going on with them. If they're on valproic acid, we need to give them a lower dose of the valproic acid and typically a lower dose of lamotrigine. Maybe the valproic acid level can stay the same. We kind of keep an eye on that with the VPA level, but clearly lamotrigine levels and doses have to be adjusted. If there are enzyme-inducing drugs, the half-life is actually shorter, and so lots of interactions with anticonvulsant drugs, particularly with Tegretol and lamotrigine of the drugs we've talked about, and some with valproic acid as well. And so you really need to do drug interaction checks when you have these drugs on board. Other side effects other than the derm problem that we're really worried about could be dizziness, ataxia, central nervous system kind of effects. And we usually start folks on lamotrigine at 50 a day and titrate them up to 250 milligrams twice a day. If they're on valproic acid, we're a little lower with that and careful about how we monitor that. A couple other drugs that we can use. One of the benzos is clonazepam. We don't really use it that much it's primarily one of the benzos that's used for seizure activity, for GABAergic activity, for absence seizures, myoclonic seizures. We don't see clonazepam used all that much in mental health, but the other benzos we'll talk about in a few minutes we can use, and we'll talk more about the benzos at that point. There are some issues with pharmacokinetics we've highlighted in a couple of the next slides, so it's sort of a review. You can look at Tegretol or carbamazepine, the typical doses that are used. In this slide, valproate or Depakote, the typical doses and half-lives that you're going to see with this drug as well. Lots of interactions we'll see. We kind of alluded to that. I really encourage you in your practice to become familiar with drug interaction software. If you're using an electronic medical record, typically that electronic medical record will flag that for you already, although there might be some exceptions to how that's done. But as you're working through this course, particularly if you're working on cases or you're trying to understand where things are, make sure you're using a drug interaction check or on the computer or on your mobile device to give you a sense of maybe how to manage those interactions. All right, so let's look at where these drugs, these anticonvulsants, fit in mental health therapy. There's some reasonably good data for Depakote in bipolar. It may be as effective as lithium in some patients. It's probably more effective if folks have a rapid cycle, and it's less effective if they are bipolar with depression. Typically, we're going to shoot for levels of 40 or 50 up to 125, and we're going to look at their albumin levels, liver toxicity, some of the adverse effects that we sort of looked at, particularly if the levels are higher, look at for thrombocytopenia, and sort of manage their adverse effects in a reasonable way. Typically, in bipolar, it might be effective in about up to 2/3 of patients. We're going to get blood level monitoring typically be in the morning before the morning dose, before the first dose in the morning. And we're going to see if folks can be managed on the lowest level they can tolerate, which might even be 40 milligrams per liter. We talked about all the adverse effects already, so I encourage you to look at these. There's a couple others listed here. There is a potential for polycystic ovarian syndrome associated with valproic acid use as well. Let's quickly look at carbamazepine. Typically, it is used for mania and maintenance therapy with folks with bipolar. In practice, I don't think we see this drug used as often as some of the others, but it can be used, and so just to recognize that's availability for mania as well. The efficacy, about 50% or so get a response rate in bipolar, and usually we start at 100 to 200 twice a day and titrate to response. That 200 twice a day dose, some folks will actually get GI upset with that, so some folks start at 100 milligrams twice a day for a day and then move up to 200 twice a day, and then getting blood level monitoring periodically with it. We talked about the adverse effects of carbamazepine, including GI upset early on and the risk for leukopenias and hepatotoxicity, which is rare. But you want to keep an eye out for that, as well as central nervous system things that look like sedation, unsteady gait, visual disturbances. And then if their white count falls below 4, then typically we look at holding or discontinuing carbamazepine. Lamotrigine probably has a stronger role. Another anticonvulsant we didn't talk about is topiramate. Topiramate also has some data for bipolar, and depending on which practice area of the country you're in, we'll see that some clinicians in mental health have more familiarity with one of the anticonvulsants over another. In some settings, I've seen topiramate used moderately frequently as an anticonvulsant for bipolar, lamotrigine in other settings as well. But as we think about the type here of the agents, or that chart we looked at earlier, the agents we'll see used for type 1 and type 2 are listed here, and you can see that you'll find lamotrigine, lithium, quetiapine, and valproic acid are sort of the major players that sort of come up in both treatment of both types. The role of antipsychotics, particularly quetiapine or is probably the one you'll see folks use most often. Olanzapine could be as well, but we worry about diabetes risk with that. You could also see aripiprazole or lurasidone also approved for bipolar as well, but we will use them as for a manic portion. The ideal candidate for someone with bipolar for an antipsychotic is if they have concurrent psychoses, or they're very highly irritated, or they're aggressive. Those are the folks for whom treating their mania with one of these agents makes a lot of sense. We'll talk a little bit more about benzos in a bit, but the benzos for benzodiazepines for bipolar aren't really all that helpful. They might help with agitation, but they're not really all that helpful in mania per se, and so we try to avoid them. Another reason we try to avoid benzos is because they're control drugs, and folks who have any mental illness, or mental health issues, we often worry that you may be layering on a potential risk for substance abuse. And not that we overly worry about that. If you really have an indication for using a benzo, then certainly we will. But if you have alternative therapies and benzos really don't get to the core symptoms, why add a drug on board that has a potential for leading to a problem with dependence, which is like yet another problem for a patient when you can really find alternative agents. So benzos have sort of fallen a bit out of favor in use in mental health, except for acute management of acute symptoms of anxiety.